First of all, let me offer a big thank you to the Minister of Health for this tremendous opportunity to talk about newborn screening in the EU and, of course, particularly in Slovenia. And thanks also go to Dr. Tadej Basilino for his encouragement and hospitality and for helping to host this exciting event. We're going to hear particularly from Italy. We'll also hear from France, from Slovenia, from Germany, from Sweden, from the Czech Republic, and from Southeastern Europe. It promises to be an exciting morning, and perhaps most importantly, a morning from which we can learn from one another. But before we do that, I'm going to give a brief overview of the current state and future of newborn screening in the EU on behalf of the ISNS. The ISNS is the International Society for Neonatal Screening, and I have the great privilege to be president of that organization, with members in over 80 countries right around the world, including, of course, Europe. So we've got much to share together and much to celebrate. It's now around 50 years since Robert Guthrie first described a test to detect phenylketonuria, a condition which, if not recognized early, leads to severe developmental delay and very often long-term institutional care for those who are affected. If, on the other hand, it is detected early and asymptomatically by newborn screening, these children can have a normal outcome. And that was absolutely revolutionary. And we've got to thank Robert Guthrie for that, particularly for the test, which could identify phenylketonuria, who was a microbiologist and described a microbiological assay that we no longer use. But he also described a means of collecting the sample onto a dry blood spot card, so that could be sent easily to a testing laboratory. And that we do still use. And that was a singular achievement upon his part. Since then, worldwide, we've probably detected around 100,000 children with PKU who have benefited enormously from that life-changing intervention. And of course, excited by that, doctors around the world saw the success of screening for phenylketonuria and considered if there were other conditions which could also be included. And next on the list was a much more common condition, 6 times as common as phenylketonuria, the condition congenital hypothyroidism. And that too could be radically changed in terms of outcome for the children affected by this simple treatment with thyroxine, provided they were identified early. And these introductions led many around the world to describe the process of newborn screening as one of the major public health advances of the 20th century. So is it all good news? Well, largely it is, and newborn screening has been a hugely significant advance. But nevertheless, we do need to be careful. We need to be careful because, of course, the patients and families at the time that they're being tested believe that their child is well. They're asymptomatic, they've got a new baby, it's the first week of life. They're excited with the arrival of the new baby that looks absolutely perfect. So anything that comes along to upset that, and particularly if it were, for instance, a false positive result, would be a matter of great concern for the family. And that's why Muir Gray, a former director of newborn screening in the UK, coined these important words in an article in the British Medical Journal. He said that all screening programs do harm, some do good as well, and of these, some do more good than harm. And if I were to complete that, it would be at reasonable cost. And what that tells us is, as with most of medicine, is that screening is a balance. It's a balance between doing the good that we seek to achieve, but nevertheless minimizing any side effects that occur as a result. What it does tell us is that more screening for more conditions, does not automatically mean better screening. It can be a gateway into life-changing benefits, but if it's not done properly, it can also lead to problems for families. So what we keep saying within ISNS, the organization that I represent, is that screening, which is well organized and delivered as a carefully monitored program linked to structured treatment, is what we should aspire to. So with that kind of caveat right at the outset, because that frames really the agenda for today, to try and develop that well-organized screening to deliver it for as many conditions as are appropriate, then we can kind of launch off and make that discussion together. It was against that background of having to consider carefully the use of screening that in the 1990s, David Millington and Don Chase in the US developed a technique called tandem mass spectrometry, and that really was a game changer. This MSMS, as it's described, allowed the recognition simultaneously of up to 40 conditions from a single test. Prior to that, every time a new test was introduced for newborn screening, a new condition was introduced for newborn screening, it required a new test. But now suddenly we were able to detect 40 conditions from a single test. And perhaps unsurprisingly, the member states and the EU have reacted quite differently to that. Some of that have exploited that to a great extent and identified for many conditions. Others have been rather more conservative and still only screen for relatively few. And that variation in practice is not just about the conditions chosen to screen, but also the way in which the screening process, the screening program is led, delivered, and conducted. So what do we find when we look at that, when we look at newborn screening today in Europe? On the back of EU Council recommendations in 2009 on rare diseases, the ISNS and others responded to a tender invitation to do a survey. And that survey was conducted in 2010 and showed a great degree of variation, both in practice and in the number of conditions screened. There were some recommendations made back to the European Commission on the basis of that survey. And then the survey has recently been repeated some 11 years later. Gerard Leber, whose name appears on the slide there, was instrumental in arranging that first survey and has diligently kept that up to date. And that was published in the International Journal of Neonatal Screening earlier this year. And what it shows is, while there has certainly been progress across the EU, and that's a great thing to celebrate, there is still considerable variation in practice. So for instance, in our member states, the number of conditions screened varies from 2 in some member states to 35 conditions. And that really is quite a marked difference. But it's not just about the number of conditions that are screened, it's the way that we do that screening. So the date of sampling, the date when the sample is taken, which is pretty crucial in the newborn screening process, varies from 24 hours to 120 hours. The time that it takes for a sample to be transported and analyzed varies from a couple of days up to a month. Whether or not screening is optional or compulsory for our population varies, and you can see the figures there. And a pretty basic thing, such as whether or not our families are informed of the outcome of screening, varies. And they are in only 25% of countries, but are not in 75% of our countries. And that, again, would be a cause for concern. And then particularly topically today, of course, when people are rightly concerned about privacy and data security, the consent to the storage of the residual sample is asked for, again, probably in only around about 25% of our countries. So quite a degree of variation in practice. Of course, the degree of variation in practice brings with it not just a negative, but also the opportunity to learn from what is best. And that's part of the agenda for today, to explore what's going on across Europe. So how do we seek to resolve this variation in practice across Europe, both in terms of the number of conditions and in the way that things are done? Well, I think probably the first important thing to say is that seeking equity doesn't necessarily mean doing the same thing in every situation. It means doing the appropriate thing in the right way at the right time to achieve a commonality of benefit for the children that we serve. And crucially, of course, when we're thinking about the practice of screening, to ensure that good practice becomes common practice in all of our countries. Why do we need to do that? Well, to some extent, achieving the best possible outcome for our children is self-evident. but particularly at the minute, we stand at the verge of a genetic revolution. Genomics is rapidly providing new opportunities to treat rare disorders, but those treatments are very expensive, and so we need to be careful in the way that they're applied. And genomics is also providing new means of detecting those same conditions, sometimes by screening and sometimes by normal clinical investigation. And what we can easily see, that unless we take stock now and make good practice common practice and work out ways of achieving equity, then we'll see increased divergence as these genetic treatments and diagnostic techniques become applied differently in different member states. Now really is the time to act. So if we're going to act, what strengths do we have? Well, we do have some considerable strengths. I think all of our health systems already recognize that newborn screening is a significant benefit. All are engaged in newborn screening, and that newborn screening already enjoys considerable political support. It also enjoys widespread public support. Decline rates for newborn screening, where it's voluntary, are less than 1 in 1,000. And that's a marked contrast, perhaps, to the wariness about vaccines that we see in some of our member states. To help guide decision-making, all policymakers recognize these Wilson and Jugner criteria are important when making decisions about which disorders to choose. Wilson and Jugner first coined these straightforward and simple to understand criteria back in 1968, right at the time the screening was beginning to emerge in terms of newborn screening. And they're really self-evident. Things like the condition should be important, there should be an accepted treatment, there should be a test which is acceptable to the population, and that we understand the natural history of the condition. And of course, crucially, there's an agreement upon who to treat and how to treat and when to treat. So many of these criteria are widely shared. So given that we all recognize the importance of newborn screening, and given that we share criteria to make choices, why do we see such difference from one member state to another? Firstly, it probably rests upon the level of evidence required. Some countries require published peer-reviewed evidence of benefit before accepting a condition into the national screening program. Others, on the other hand, will accept simply the recommendations of senior clinicians within their country that this would be of benefit without necessarily having published evidence to that effect. Some administrations require cost-effectiveness studies and the demonstration of a cost per quality adjusted life year that is better than the threshold set. And others don't apply that restriction before conditions are included. Perhaps most crucially, the makeup of the decision bodies themselves varies. Where they are dominated by professionals from a public health background, they tend to be rather more conservative. Whereas when the doctors faced with seeing these patients who have not been screened and detected early predominate in the decision-making group, then as one could imagine, there's a tendency to want to include new conditions within that list. And of course, finally, the level of direct political involvement. If politicians, we've said that it's a popular political thing to engage in newborn screening, and where politicians, influential politicians get involved, then we often see conditions being included, particularly at their encouragement. So how can we, against that background, how can we progress? Well, I think firstly, we've got to recognize that we really do owe this to the next generation, not only to do screening when it's appropriate, but to do it well. We can raise awareness, and this year, 2021, marks the first of International Neonatal Screening Day, which is on June the 28th and be celebrated again next year. And that day was chosen to celebrate the birthday of Robert Guthrie that we mentioned earlier. We need to develop trusted information sources that can be trusted not just by health professionals and the public, but also by health policymakers. That is something which is free from bias and certainly free from lobbying, which really deals with evidence. And that's what we've been trying to do within Screen for Rare. We need to learn to share information in a systematic way. Many of our member states already have done pilot schemes for particular conditions. For instance, severe combined immune deficiency has had a pilot scheme in France, it's had a pilot scheme in Germany, it's had a pilot scheme in the Netherlands, and we're now starting a pilot scheme in the UK. But very often, the outcomes from those are not shared in a systematic way. So then we must repeat that time after time. And of course, it would be good to think that we could design, if you like, a template for pilot schemes, which would allow information to be shared. Crucially, we need to have shared case definitions for the conditions that we identify, seemingly obvious, but not always in place. And we need to look at long-term outcome studies so that we can really measure and analyze the benefits of screening and learn from that experience to improve it. And we need to work with and alongside health policymakers to inform without challenging important national autonomy, which must be preserved. We must encourage by the provision of information. And to help that, it would be enormously useful to develop a newborn screening expert group, which is recognized by the European Commission as a source for unbiased, evidence-based advice. And that is one of the deliverables that we would really long to see coming out of this meeting today. So where are we now and what next steps might we take? We've already formed with EC support an EU health policy platform to house some of that reliable information which we've discussed. We formed a European reference network screening group. Of course, the European reference network's key to the rare diseases policy within the EU, and they have a great interest in newborn screening because, of course, if patients are identified early and asymptomatically, the outcomes are usually much better. This is the second in a series of high-level meetings that we hope to use to raise awareness of some of these important issues. The first was a meeting of the European Reference Network Screening Group just over a month ago, back in September. And of course, there is this important meeting now hosted by the Slovenian presidency. And then we have a special event at the ISNS European Symposium just 1 month from now, moving towards newborn screening as a system is the title for that. And we hope these will be milestones in trying to build awareness and build a strategy. We've got some international exposure for the exciting work that we're doing in Europe, and the American Public Health Laboratory meeting on the 6th of October is receiving a presentation about just this, about the work that we're engaged in today. We need to chart a way forward, and we need to chart that way forward together by learning from one another, and that's one of the goals of this meeting. Thank you very much for listening. And now, as I promised, against that general background, we're going to hear some of the good things that are going on in our member states. And I'm delighted to be able to introduce Giancarlo Le Marca from Italy to tell us the good things that have been going on in Italy and what we might learn together from that. Thank you.
Good morning, Professor Bonham, and thank you very much for your presentation. My name is Giancarlo Le Marca. I'm the president of the Italian Society for the Study of Metabolic Diseases and Newborn Screening. Let me give you some information about the Italian program for newborn screening and some information about our newborns. As you know, our Italian population in 2020 was a little bit higher than 60 million, with a little bit more than 400,000 newborn. We had a reduction of 13% in the last 4 years and higher than 30% in the last 12 years. As you know very well, the history of newborn screening dates back at the beginning of the 1960s, when Robert Guthrie developed a very easy and cheap test for the detection of the most frequent aminoacidopathia, the phenylketonuria. Early in the 70s, also in our country, newborn screening for PKU started. In Italy, neonatal screening is mandatory by national law since 1992, and this law entered into the force and remained active up to 2016. At that time, in 1992, newborn screening was mandatory for the entire neonatal population only for 3 disorders: phenylketonuria, congenital hyperthyroidism, and cystic fibrosis. And at that time, in 2016, we had 32 newborn screening centers in the entire country, covering and serving for less than 15 newborns per year per lab. In 2016, what is normally considered and called expanded newborn screening, especially by means of mass spectrometry, through some pilot project, was covering only 50% of our neonatal population. In the same months, the law number 167. Today, newborn screening program is considered in our country an essential public health service, covering up to 40 disorders, including aminoacidopathias, organic acidurias, urea cycle defects, beta oxidation of fatty acids, galactosemia, and biotinidase. Moreover, the entire cost of the program is covered by central government, up to 26 million euros per year. The new law 167 entered into force on March 2017, strongly recommending interregional agreements. And I'm proud to say you that today we are able to reduce the number of newborn screening centers from 32 up to 15, covering the double number of newborns per year per lab. The newborn screening is today considered not only as a test, but as a multidisciplinary and organized program, where quality is a key characteristic. Quality is not only a research option, but should insert and ruled by law. Quality means good and correct family education and information through national leaflet, if active, eventually also through regional material. Correct information means use of easy words, right information in different and most common languages. Moreover, formation, information, and empowerment are strongly recommended for families, for nurses, and also for technicians. We have a permanent school on newborn screening for technicians and chemists and biologists. We had an international school on mass spectrometry and clinical chemistry in 2018. And today, a new university master for medical doctors and laboratoricians is activated. The newborn screening program consists of 3 levels: newborn screening lab, confirmatory laboratories, and clinical centers. And all of them are ruled by national law. The newborn screening lab should have specific personnel, chemists, laboratoricians, medical doctors, and also specific instrumentation and machine. The first year test should be done 7 days per week, also working in emergency. First year test should be coupled to second year test when available, because all newborn screening programs could generate false positive results. And false positive means parental anxiety and associated cost increase. And the coupling of first year and second year test improve the specificity and the positive predictive value of the system. Confirmatory labs should work 24 hours, 7 days per week, and also they should operate in emergency regimen. Both labs, newborn screening and confirmatory labs, should work in quality by performing quality control and proficiency testing, national and international, and also clinical center for newborn screening should be ruled by law. The last slide for you for today is the future perspectives in our countries and the national expansion of our panel for SMA, severe combined immunodeficiencies, and some lysosomal storage disorders is under evaluation by a specific Ministry of Health committee, and in the next future, disorders should be added to national program. Thank you very much, and I leave the floor to next speaker, Dr. David Cheillan. Thank you very much.
Thank you for Professor Le Cam for his introduction, and thank you for the organizer of this meeting for his invitation, especially to Peter Cheillan. And I would like to present you the global overview of newborn screening in France. So newborn screening started in France in 1968, and our population is approximately 67 million inhabitants. And we have a number of newborn per year, approximately 760,000. We have 12 regions and a few overseas territories. And in France, newborn screening is mandatory. Actually, we screen for 7 disorders, 6 disorders on the Guilty cards, and 1 clinical screening for hearing disability. The global exhaustivity of this program is over 99.5%. Regarding the organization of newborn screening, we have at the regional level 17 regional centers with 16 newborn screening laboratories, which screen approximately from 25,000 to 180 newborn per year. At the national level, we have all the regional centers represented by a national coordinating center and containing 2 commissions, 1 epidemiological commission in charge of the global evaluation of the program, and 1 biological commission in charge of the follow-ups of the biomarkers, the definition of new algorithms, and the setting of the cutoffs. Finally, in the Ministry of Health, newborn screening steering committee is in charge of the global political decision and in association with the National Agency for Health Recommendation. So what about the result of the screening in France? We have for phenylketonuria a measurement of phenylalanine since 1972 with a global incidence of 1 to 16,000. For congenital hypothyroidism, we screen with a measurement of TSH since 1978 and with a global incidence of 1 to 3,000. For congenital adrenal hyperplasia, we measure 17-hydroxyprogesterone since 1995 with a global incidence of approximately 1 to 20,000. We screen also for sickle cell disease, but only on a selected population, which represents 30% of the global population of France. With a measurement of hemoglobin S since 1989, with a global incidence of 1 to 1,000. Cystic fibrosis, we measure IRT, DNA IRT since 2002, with a global incidence of 1 to 5,000. And finally, we screen for MCAD deficiencies since only 2020, with a measurement of C8 and C10, with the first result, global incidence of 1 to 20,000. And for hearing screening, where we measure auditory evoked potential at the clinical level, and since 2013, with a global incidence of approximately 1 to 1,000. What is the future of newborn screening in France? We plan to extend our program to 7 other inborn rough metabolism with different amino acidopathies, different organic aciduria, and some beta oxidation defects. And we have another condition under evaluation, which is a severe combined immunodeficiency named SCID. And we must have a decision at the end of this year. So thank you very much for your attention. I invite my colleague, Dr. Grošelj, for the presentation for Slovenia.
Thank you very much for a kind introduction. Now I will present briefly a newborn screening program in Slovenia, its past developments, its present status, and our future plans. Also a pathway in the last decade from a relatively modest program to one of the, I would say, most modern programs existing. So the newborn screening system in Slovenia is actually comprised of one central MBS center located in University Medical Center Ljubljana, and 4 additional maternity hospitals, which are dispersed through Slovenia. In general, Slovenia has a population of 2 million people, and live births are 9.5 per 1,000 of population. In 2020, we had 18,363 births. Newborn screening in Slovenia actually started in the year 1979 with the introduction of screening for phenylketonuria, and 2 years later, congenital hypothyroidism screening followed. In the next year, Also, some other screening, non-biochemical screening programs were introduced, like screening for hearing impairment, ultrasound of hips, and some years later, also screening for optic media translucency and saturation in limbs. But the first biochemical expansion of newborn screening happened only in 2018 with introduction of 17 other inborn errors of metabolism. The second expansion is planned in the year 2022 with introduction of cystic fibrosis screening, congenital adrenal hyperplasia screening, inborn errors of immunity screening, and spinal muscular atrophy screening. And we also plan regular next expansions every 3 to 5 years. When we planned the first expansion in 2018, we first prepared a pilot study, which was also focusing on next generation sequencing as a follow-up test in an expanded newborn screening program. And after the expansion of newborn screening, we also prepared a quality control study, including the first 15,000 screened newborns, which showed that 2% of them had either borderline or positive screening test results. All the facilities, including maternity hospitals and the central screening facilities, are connected into common IT network, which enables ordering tests, which also enable results authorizations and results distributions to all the maternity hospital who order actually the test. We also introduced barcodes on the DBS cards to enable a good traceability of DBS cards and also enable retrieval of information of individual patients, which is especially important when we urgently need this basic information about the patient. So the flow chart is as follows. If the result is borderline, we repeat the analysis from new DBS. If it's positive, the child is directly referred for further clinical and laboratory checkup at the University Children's Hospital, Ljubljana. If the repeated DBS sample is positive or for the second time borderline, also this group is referred to the University Children's Hospital, Ljubljana, where we frequently proceed with the NGS testing, and in some cases also with further enzyme activity analysis. The samples are in these cases sent abroad. We have an in-house gene NGS panel of 72 genes for confirmatory testing for newborn screening. It is performed in all screening positive cases and frequently also if the results are unclear. Pending is the development of DNA isolation method from DBS card, and we plan also to introduce real-time PCR for spinal muscular atrophy and immunodeficiencies screening next year. So this is our in-house gene panel comprised of 72 different genes. And as mentioned, next expansion will happen next year as planned. We will introduce spinal muscular atrophy, newborn screening, and selected inborn errors of immunity newborn screening. Those will base on real-time PCR. We will also introduce cystic fibrosis, newborn screening, and congenital adrenal hyperplasia newborn screening based on immunochemistry methods. If we put newborn screening into a broader perspective, out of over 7,000 different rare diseases, only around 50 are being currently screened by best newborn screening programs. So there is actually a huge room for further expansions in the future. To conclude, in Slovenia until 2018, we screened only for 2 diseases biochemically. From 2018, we screened for 90 diseases. And from 2022, we plan to be screening for over 40 diseases. What is important is to engage all the stakeholders into the MBS ecosystem at both the national or regional level, to include the common IT platform, and also that they're connected at the laboratory and clinical levels. With currently screening for less than 1% of rare diseases, each newborn screening center should be or should expect the further expansions of newborn screening. And of course, in future, there will be an increasing role of genetic testing, which is now mostly confirmatory. Thank you for attention. And as a next speaker, I would like to introduce Professor Stefan Koelker from the Heidelberg University.
So thank you, Professor Grošelj, for this presentation, and thank you for the organizers to inviting me and to give the opportunity to present the situation we have in Germany and focus on how outcome studies improve newborn screening programs. So in Germany, like in many other European countries, newborn screening has been started with the seminal work of Robert Guthrie and Horst Bickel, which allowed to early diagnose and treat individuals with phenylketonuria. After 15 years now, the newborn screening program has been extended, including now 19 different diseases. As said, I would like to focus on the importance of observational studies in order to address the most important question of newborn screening program, and that is whether they really have an impact on the health of affected and early screened individuals in the long run. In order to address this, we have started long-term observational studies in Southwest Germany more than 20 years ago. And in this area, we cover about 20% of screened newborns. And in recent years, we have extended this to establish national cohorts for single inherited metabolic diseases. And by doing so, we now include more than 90% of screened individuals. Looking from the eagle perspective, we can say that newborn screening really resulted in an excellent neurocognitive development and outcome of these children, as you can see from the tests that we have done in a structured way. And it also allowed these children, the majority of them, to attend regular kindergarten and regular primary school. However, if you dig deeper, you can see that what I've said is not true in the same way for every disease and every individual, because for inherited metabolic diseases, some of these diseases are so severe that they already present with symptoms before newborn screening results are available. And so therefore, newborn screening programs cannot prevent acute and mostly neonatal disease manifestation in all of these diseases, as you can see here. However, what we've also learned from these studies is that although some of these have acute disease manifestations, this will not necessarily result in permanent disease manifestation, because not after every of these acute events, these individuals suffer from irreversible organ dysfunction. So therefore, the majority of early screened and treated individuals remain asymptomatic until adolescence or even adulthood. However, you see that there are diseases which have a less optimal outcome after newborn screening because they develop neurologic symptoms. Some of these diseases is glutaric aciduria type 1, where children may develop striatal injury if inadequately treated. We could show that with the prescription of an adherence to recommended therapy, the majority of these individuals still have an optimal outcome and remain asymptomatic. That means we've highlighted here that therapeutic quality becomes the major predictor of outcome in a screening cohort. Another aspect we have learned from these studies is that the case mixes of individuals of newborn screening and pre-newborn screening cohorts often differ. And this is important in terms of case definition, risk stratification, and based on this therapeutic indication. And finally, also the correct evaluation of newborn screening programs. One example I provide here is isovaleric aciduria, where we have in the blue area individuals with a severe phenotype, and in red it's depicted a mild disease variant group, which is quite prevalent in Germany. As you can see, both groups differ in terms of the frequency of metabolic decompensations, but also in terms of neurocognitive development. So if you would put both groups together and would not differentiate them, you would overestimate the result of newborn screening program in Germany for this disease. Certainly, you can also imagine that there is ongoing discussion about to what extent individuals with a mild IVA disease variant require treatment in order to avoid overtreatment. So let's come to my conclusion. By doing these studies, we've learned a lot of lessons which can guide newborn screening strategy. We've learned that newborn screening is the prerequisite of favorable clinical outcome. But in order to achieve this goal, we have to address a lot of different aspects like optimal diagnostic process quality, safe and effective therapies, and evidence-based clinical care guidelines. So what we have achieved on a national level, can we also achieve on a European level in order to optimize and continuously improve newborn screening programs on a European level? For this, we require transnational collaborative collection of outcome data and comparative data analysis. Thirdly, such an effort would require some funding and some support in order to achieve this goal for the sake of the patients and for the sake of improving newborn screening on a European level. I thank all my collaborators on a national and European level who have supported these studies for many, many years, and without them, it would have been impossible. And I would like to thank you for your attention. And now I pass on the word to Professor Zetterstrom from Sweden. Thank you.
So thank you, Stefan, and thank the organizers for being invited to this stimulating meeting, and I have nothing to disclose. So the Swedish PKU laboratory was founded by Hans Palmstierna and started screening for PKU in 1965. And since 1998, PKU laboratory is one of 4 units at the Center for Inherited Metabolic Diseases, which is a multidisciplinary organization combining clinical medicine, clinical chemistry, and clinical genetics, including specialists in pediatrics, neurology, endocrinology, and bioinformatics. At present, we carry out the newborn screening for approximately 117,000 newborns per year, and we have follow-up of approximately 1,000 patients with PKU and CAH and some other IEMs. Since 1975, we have all our filter papers stored in our biobank, and this has been very, very useful in assuring quality of the screening program, and also for making, for example, CMV diagnostics and doing research. So at present, we screen for 25 disorders in Sweden. The two endocrine disorders, CAH and CAH, are all referred to a pediatric clinic by a pediatric endocrinologists in the laboratory. When it comes to the metabolic disorders, they are all referred to one of 4 specialist pediatric metabolic units in Sweden. And SCID are referred to one of 3 specialist centers for primary immunodeficiencies. We carry out second-tier analysis for CAH, MMA, PA, homocystinuria, IVA, and GA1. And this is to improve precision of our test. And we have approximately 80 to 100 true positive cases per year in our screening program. So the process of implementing new screening disorders in Sweden is a program that is hosted by the Swedish Board of Health and Welfare, and the important decision is made by the Screening Council, consisting of professionals as well as politicians from the different regions in Sweden. First of all, the 24 disorders already in the program was evaluated and got accepted. And then in 2019, SCID was introduced in the program. XALD was evaluated 2020 and was a no, and CF and SMA are now under and ongoing for in evaluation process. So for us, the international collaboration has been extremely important. And when we extended our screening program in 2010 with 90 new disorders, it was very helpful to have help from R4S that later developed into CLEAR. And we have also over the year have a lot of contact with the Nordic countries and some other laboratories and organizations that has been important. I also would like to mention ISNS as a very crucial organization for us and for the Newborn Screening Society. So after the extension of the screening program in 2010 with these 19 new disorders in the program, we realized we needed a registry, and we got funding to start a registry for follow-up of all the inborn errors of metabolism that we were screening for. And that was ready to go live in 2013. So this is a presentation of what the registry looks like, and it has been very useful, and I use it all the time when I see patients because it's ideal to follow things over time. And all the blood Phe values, for example, for the PKU values, are transferred electronically from the PKU laboratory, both to caregivers and patients' families. And we also have a lot of the other patient controls for other IAMs that are directly exported from the laboratory into the registry. And so this is just an example from our annual report for 2020, where we can see all the PKU patients in Sweden that we have in the registry and the blood Phe values that they have. And I think the strength with this is that all the values are actually here and no values are missing, since all the data is exported from the laboratory carrying out the analysis. And with that, I would like to thank you all for your time and for your attention. And I would like to pass on to my colleague and friend, Viktor, who will continue.
Thank you, Rolf. I will continue with some experiences from the Czech newborn screening program. Just a few quick facts. We are screening over 110,000 of newborns every year with a very good uptake. At present, we are targeting 18 disorders and using second-tier tests for selected diseases. The legal basis for newborn screening is a methodical recommendation of the Ministry of Health. We do have 2 clusters of laboratories, one in the western, one in the eastern part of the country. Each cluster contains 1 laboratory for tandem mass spectrometry, 1 lab for immunoanalytical methods, and 1 genetic testing lab for second tier for cystic fibrosis. In the past 11 years, we screened for about 1.2 million newborns. Now we are approaching detection rate 1 in 1,000, and the false positive rate after excluding congenital adrenal hyperplasia is quite reasonable. I will focus my talk on experience with pilot studies and on expansion of newborn screening programs. As in other countries and in other programs, we gradually increased the number of diseases, starting with PKU in 1985, having 18 disorders as of 2016, and there is a pilot planned for SMA and SCID in 2022. As you may see, expansion was always preceded by pilots, and I will focus now on the two approaches. So far, the expansion of newborn screening programs and pilots was initiated by newborn screening specialists. So I call it a bottom-up approach. And in 2009, we felt that we need coordination of our activities. So the Ministry of Health established a coordination center with representatives of laboratories, Ministry of Health. We are peer reviewing the IEM cases, and we do have annual meetings to evaluate the program. These pilots are quite lengthy because since the grant application to implementation in routine, it usually takes about 5 years. There are extra resources needed, typically 300,000, 400 euros in the recent pilots, and it's also personnel intense. Because there needs to be an extra information and an extra informed consent for research, and this is going to the busy maternity hospitals. The pilots can give us an information about population distribution of markers. It may help to define decision limits, and it also tests the patient care pathways. However, finishing a pilot doesn't mean that it will be transferred into practice. It needs governance. The last pilot was approved first by the Interdisciplinary Committee for Rare Disorders, and then all pilots are being approved by the Ministry of Health, which issues a new methodical recommendation for expansion. It is also important to obtain a reimbursement new laboratory code. There is also a different approach, which is now being tried. I call it a top-down approach, which was initiated by politicians, patient organization, and other medical specialists who are primarily non-newborn screening experts. The present pilot is governed by and organized by the National Screening Center, and it is a pilot for SMA and SCID. It's expected to start in 2022. The possible issues of concerns are several. The major issue is the conflict with the Act on Specialized Healthcare Services, because our legislation requires a pre- and post-test genetic counseling for genetic testing, and this is now to be solved at the highest level by politicians. And there are also concerns about the amount of dry blood spots and its quality. In the past, we have experienced complications or issues with human rights activists who were against any genetic testing using dry blood spots. So my personal comments on expansion, there are different approaches possible. The pilots require extra resources, both financial and personal. There are no clear instructions or ways how to evaluate the results of pilots. We should practice evidence-based medicine in our daily life. And I'm asking a question, can we benefit from sharing experience in newborn screening expansion? Probably yes, if we define necessary elements of pilots. Maybe if we do multicentric pilots in several EU members, I think we should stick to universally acceptable case definition. Perhaps we may use some elements of health technology assessment, but the most important question is, will the member states be willing to use such results? We probably will not be able to solve everything, like reference values, disorders to screen patient care pathways. I would like to acknowledge my collaborators and Jim Bonham and ISNS members. And this slide indicates that the virtual floor should go to Dr. Urh Grošelj. Thank you.
Thank you for kind introduction. In my next talk, I will speak about the newborn screening in Southeastern Europe and Western Balkans, which is also one of the regions of priority of Slovenian EU presidency. Southeastern Europe is comprised of around 14 or 15 countries in that region, with total of over 70 million people of population. 8 of these countries are part of the EU and some other are bordering EU. This region is very diverse in terms of economic development. Some countries are considered developed and some are still developing. And until recently, there were only scarce data available on existence of NBS programs in this region. We performed 2 survey studies in the past 10 years. One was performed in years 2013-2014, in 2020, and finished in 2021. We had aims to assess the situation regarding newborn screening in the region and to establish an informal group of involved professionals. These are the 2 resulting publications, which I will briefly present. So the number of diseases screened in 2013 was uniformly very low in the region. There was only 1 country with 3 or more diseases. Some of them had only 2 diseases, some 1 disease, and 2 countries had none of diseases included. But here we didn't include the Hungary and Greece in that survey. In 2020, the situation was much improved. 2 countries had more than 10 diseases in the MBS program. 3 countries had 3 to 10 diseases, but still there were 2 countries with none of diseases screened. The type of newborn screening in 2013 was almost uniformly basic one. But in the year 2020, more than 3 countries had expanded newborn screening programs with some additional pilot or institution-based programs also introduced. The proportion of newborn screened in the year 2013 was relatively low. Only 5 out of 13 countries had coverage rate of over 90% of population. But in the year 2020, the situation was much better. Now, some of the countries went over the 90% of coverage, and some others went over the 80% of coverage. And in 2020, most of the countries from the region had some plans to further expand the newborn screening program. So what were the main obstacles for further expansion of newborn screening? Most of the responders actually mentioned lack of financial resources, organizational aspects, lack of staff, lack of political will, and a bit less important was later management and small incidences of disorders to be potentially included. To conclude, the region of Southeastern Europe, Western Balkans is a very diverse one, are still lagging behind of standards for NBS best practices as of year 2021. We noticed a modest degree of progress in the period 2013 to 2020. So more diseases were included in some countries, better coverages, and actually there were existing more expanded NBS programs, but perhaps that progress was a bit less than what was planned. We also assessed the barriers perceived. Main ones are lack of finances, problem with organizational aspects of the program, lack of staff, lack of political will. So we would like to actually propose that there should be a strengthening of international and regional cooperation so that at least basic NBS infrastructure is present throughout the region, perhaps by sharing best practices models, by accommodating exchange of people and practices, by help with preparing applications for financing on the national level, and possibly the role of EU institutions could be increased. Thank you very much for attention.
Thank you, that was great. And indeed, thank you to all of our speakers this morning. That's been tremendously informative and very interesting. And we've heard a lot of things that can stimulate us, a lot of things that we can look at as good practice, but we've also, as Urh was talking about there, heard of challenges that we need to rise to and take forward. We've heard from the countries, and now we're going to hear from other support organizations. Screen for Rare that was mentioned at the start, EURORDIS, and of course, the hugely important European reference networks. So I'm going to pass over now to Johan Prevot to start this interesting session. Thank you.
Thank you, and thank you very much to the organizers for inviting me to this important event. And I'm delighted to address you all today on Screen for Rare, an EU joint stakeholder initiative on newborn screening. And so my name is Johan Prevot. I'm the executive director of the International Patient Organization for Primary Immunodeficiencies. So a few words about Screen for Rare. Screen for Rare is a multi-stakeholder initiative which was launched by IPOPI, my organization, together with the International Society for Neonatal Screening, or ISNS, and the European Society for Immunodeficiencies, ESID. We have been working together, and we've been building on a long-standing collaboration between our organizations, first working also at the national level and then at the European level. Our ultimate objective is to ensure that all babies born in the EU can benefit from equitable access to newborn screening, which can be a life-saving tool for conditions and sometimes even curative in the case, for example, of SCID newborn screening. We also believe that the EU can play a key role as a support base to its member states and ensure more equitable access to babies born in the region. And I think we are really fully committed to work and collaborate with the EU institutions in pursuit of that goal. So one of our first actions dates back from December 2019, when we launched a call for action. This call for action has been supported by over 30 members of the European Parliament and a number of organizations, some of which are in attendance today. And it forces three specific actions: the development and implementation of overarching guidelines in the field of newborn screening, once again with the view to assist member states and to help member states in preparing their healthcare systems for the implementation of a newborn screening for a specific rare condition. The second objective pertains to the development of an EU-wide platform on newborn screening for rare diseases, where we can pull from the expertise of recognized societies working in the field. And we think that this can be achieved by following up on the 2012 report on practices in the field of newborn screening for rare disorders, where several crucial recommendations were actually made, including the creation of a European newborn screening standing committee, something that I think we will discuss again today. Last but not least, the cooperation to position the EU as the central point for data collection and information on rare disease newborn screening practices, and encourage the exchange of best practices that would again in turn support member states' efforts in the development and optimization of newborn screening programs. And this call for action has been the basis of our work with the EU institutions. It's also been the basis of the launch of an MEP, a members of the European Parliament interest group on newborn screening that is starting to work on the matter as well. And it's great to have the intervention of MEP Pizarro and Konechna today at the meeting. So we have been also working very much with the European Commission to organize the launch of an ERN newborn screening expert platform. A first meeting was organized in February of this year, where 19 out of 24 ERNs were in attendance and agreed that it would be an excellent initiative for the European reference networks, which they believe are centrally placed to contribute to optimizing access to equitable newborn screening across the EU. And as you can see, we have established 3 work streams, one on developing a blueprint of newborn screening, case definitions, and supporting the development of registries and interoperable registry data. And Metaburn and Rita in particular have been pivotal in organizing this meeting. And you can see that there were a number, or that there are rather a number of ERNs engaging as well. On the fact that we also launched the first International Neonatal Screening Day on June 28th this year. It marks the birth of Robert Guthrie, inventor of the Guthrie card. And I think in future, this will be an excellent opportunity to raise further awareness, because this is something we really need to do. It's raising awareness about the value of newborn screening for rare diseases patient populations. So this is my last slide. I think that today is a key step for discussing a supportive EU approach to newborn screening for rare diseases, to achieve more equitable access to newborn screening across the EU, and to ensure we prepare for the future and a fast evolving newborn screening landscape. We've seen a lot of progress in the last decade, and I think we can expect very exciting developments in the decade to come. And that means that the EU has to see newborn screening as a priority in its rare diseases environment. Screen4Rare is certainly committed to continue supporting EU newborn screening actions moving forward. With this, I would like to thank you very much, and it's my pleasure to pass the hand to Mr. Yann Le Cam from EURORDIS, who will be speaking to us about the priorities of the rare diseases patient community. Thank you.
Thank you, Johan, for this kind introduction. It's my pleasure to present the views of people living with rare disease and their families on newborn screening. And first and foremost, why it's a priority for EURORDIS and for the 30 million people living in Europe is that the early intervention can prevent the onset of the disease symptoms or delay the disease progression, hence improving the quality of life of the newborn, delivering a benefit for the patients as they grow up, but also to their families and society, particularly as the care are being improved and as there is new transformative or curative therapies coming in. My second message is to say that we've developed 11 key principles on newborn screening, which were based on a thorough consultation process for about 1 year, involving experts, stakeholders, but also our national alliances in the countries across Europe, the European or international federations, and a large consultation of our members. The position paper was published in January 2021, together with a call to action. In these key principles, I insist first that from the perspective of the patients and the families across Europe, the screening should identify actionable diseases, including the ones which are treatable, but even when not treatable, because the management of care enables to significantly improve the health outcome and the social outcomes. And that gives a good reason, a good benefit for the newborn and the children, but also it enables family planning. The second main key principle is that newborn screening should be organized as a system with defined roles, responsibilities, accountability, and communication pathways that are embedded into the national healthcare systems, particularly with the highly specialized multidisciplinary points of care, which are the nodes of the European reference networks. And this will be further discussed in a moment. The third principle is the need for psychological and social support, not only the medical one, and to have clearly defined, transparent, independent, impartial, and evidence-based processes. Evidence-based in terms of science, but also evidence-based in terms of health economic evidence, but not only on the health economics. Dimension of the human person and the overall holistic approach and inclusion of the persons affected within society should be considered. The reason to act together at the European level on newborn screening are two. One is the European-wide standards. It's a good reason to work together. The timing, the sample collection methods, the follow-up, the information shared with parents in order to guarantee uniformity and the quality throughout the process and across Europe, but also to create these national biobanks in bringing things at scale so that we can go and move toward big data based on a larger pool of blood samples. And the second reason is to reduce inequality across Europe, which in fact at the moment are increasing between regions and between countries in Europe. So we need to work now on this reduction. The call to action is first to call the European Commission to support an expert forum. We need to sustain the momentum from the workshop today under the Slovenian EU presidency and bring together experts, stakeholders, and member states representatives to continue that dialogue and to discuss the best possible approaches. So an expert forum could be within the EU Health Forum, or could be at the GRC, or any other options that the Commission and member states will think fit for purpose. But our second part of the call to action is to call to the steering group of promotion and prevention, the SGPP. Italy has been considering in the last 6 months to trigger the process at the SGPP to bring newborn screening as a leader of good practice. But Italy needs to see the desire of other member states to support them and to encourage them and to partner with them to work on these possible best practices. So today we encourage you as member state representative to join Italy and invite Italy to take that leadership. Today it's Italy which has the most newborn screening diseases being screened, but there is other member states with significant experience or which are reviewing their strategy at the moment. And if they could join forces, that would be fantastic. And with that, it goes with the preparation of the work program of EU for Health by the European Commission. And it would be nice to have the translation of these efforts based on an expert forum discussion, based on this GPP initiative, then to translate that into the work program 2023 with the appropriate financial instruments in order to enable this collaboration on best practices between some member states and be able after that to scale it up at the broader European level. I thank you very much for your attention, and with that, I would like to hand over to Professor Maurizio Scarpa, who will discuss the European Funds networks and newborn screening. Thank you.
Thank you very much, Mr. Le Cam. Thank you very much for the presentation. What I will speak about is about the role of European reference networks in the newborn screening. We have heard already that newborn screening is an extremely important public health program, which is aimed to identify newborns affected by rare diseases in the pre-symptomatic way. This has been done in the 60s, especially in the inherited metabolic disorders. And the MetaBRN, the metabolic ERN, is indeed very much interested in this discipline. The newborn screening is performed in different manners, and we heard about in the different member states and the national health systems. And the newborn screening is supposed to be a system and not just a test. So it is a very complex medical act that requires quite a lot of awareness and quite a lot of expertise. The ERNs are for sure one of the major programs of the European Commission. It was starting in 2002 when patients affected by rare diseases went to the Commission to be interested in their diseases. And with time, we had the application of the cross-border directive in 2011, where at Article 12, there is the idea to form the European Reference Network. And in 2014, there was the Commission on the ERN. And then in 2016, the launching of the proposal to create the European Reference Network. The European Reference Network are 24. They are divided in organ and apparatuses. So we have one European Reference Network for lung rather than skeleton, rather than metabolic, neurology, and other apparatuses. The European Reference Network involves at the moment 26 countries, 300 different hospitals in Europe, and more than 900 healthcare units. These are all centers of expertise, excellent center of expertise approved by the Ministry of Health in different member states and enroll in the European Reference Network under a coordinator and satisfying quite a lot of enrollment criteria to demonstrate to be really at the top level of their disciplines. The structure of the European Reference Network is quite complex and it is extremely innovative. There are no other programs in the world like this one. It is a patient-centered and the European Reference Network has the core in the patients together with the clinician, and they are interacting with all the different stakeholders important in the health management, quality of life, and public health policy for the patients affected by their diseases. They are funded by different hospitals and they are connected with the health authorities, with laboratories, with payers, and with scientific institutes. Let's say that the contribution of the ERN to newborn screening due to the fact that the European Reference Network are multidisciplinary can be listed in these 8 points. First of all, experience. The European Reference Network are healthcare providers. They interact with medical laboratories and basic science institutes, and so they can add all the expertise needed to make the diagnosis and to have an application to the diagnosis to the patient. They can promote the equity and access to screening because the healthcare providers are throughout Europe. And for this, they can, the European Reference Network can create a sort of picture of what is the access of the screening in the different countries and collaborate with different stakeholders to facilitate the application of the screening in different member states. Communication with institutional stakeholders is one of the most important activities the ERNs are doing, because, I mean, as I said, the ERNs are a sort of bottleneck of all the different stakeholders, from hospital to payers to companies to any kind of activities that can facilitate the development of newborn screening. Education, testing, clinical service, and project management, the ERN have programs dealing with this. And of course, the newborn screening is something that it is extremely important in the activities of the ERN and the metabolic one in particular. The interaction with the patients and empowerment of the patient is one of the key objectives of the ERNs. We are patient-centered, and the integration with the family organization is giving also the possibility to answer the unmet needs that we have heard from EURORDIS and that still remains in especially in newborn screening. Technologically speaking, we have also data collection, biobanking methods for data analysis. The progress of science is asking more and more to use and reuse analysis, the data for a proper analysis. In the ERNs, we are developing all the different tools to facilitate this kind of need. To guide the decision pathways, we have all the expertise in the ERN to advise and to create opinion papers and guidelines to understand exactly what the newborn screening need and how the children need to be taken care and how to collaborate with the family for the best care of the child. Availability of therapy, there is no newborn screening without a therapy, and one of the major activity of the European Reference Network is to develop projects for the therapy, for the innovative therapy for rare diseases. Of course, the newborn screening is not a test. It is something that is going around the newborn and the family, and it is a collaboration between the healthcare providers and everybody that is involved in the communication of the disease and the management of the disease itself. So the ERNs are made of hospital where whenever they do newborn screening, this kind of system is working, and it is easy, to collaborate and to have the treatment of the family done in a proper way. Of course, the position of the ERNs, in particular the metabolic one of the newborn screening, is that the newborn screening should be regarded as an integrated system. It's not only a test, it is obviously something that requires quite technical skills, but we need also to be very careful about the ethical, the logistical, the educational, and the quality of this test. And the newborn screening is something that need to be discussed about before birth, in order that the couple is aware of what they are doing. And then after birth, whenever there is a diagnosis, to be taken care in order that they can understand exactly what they did in testing, which kind of problems they may have, and then what kind of follow-up and treatment and family assistance they need in order to take care as much as possible. And at the best way, the child with a rare disease is discovered in the preclinical time. The collaboration is multidisciplinary. You see here all the people that are involved in the newborn screening working group of the metabolic ERN I'm coordinating. And you see that there are all the major actors, patient organization, scientific organization, other ERNs, and all the programs that might be interesting this team. And only by working in a network among healthcare providers, among ERN, and among ERN together with scientific communities, like, for example, the International Society for Newborn Screening, will bring the newborn screening to be conducted in Europe in a very disseminated way and in a very equal way. So in conclusion, what I can say is that the ERNs are for sure one of the major public health programs coordinating the major expert on rare diseases. Since they are ending the first 5-year plan and ready to plan the second-year plan, this will be devoted to very practical projects impacting the patient quality of life. And for this, of course, the newborn screening is one of the major ones. The ERNs have a natural structure to contribute to high-level discussion and planning of social programs, and they have the expertise, both at technical and organizational level, to really facilitate any kind of visionary project like the newborn screening in Europe in different national health systems. The most important thing is that we are also discussing and producing data and tools in order to collect everything that is generated by such a community program, and to be applied in programs that can optimize and customize the different newborn screening approaches. I hope that this was giving an idea about the impact that the ERN could give to the European community. And now I'm happy to introduce you Dr. Pizarro for the next presentation. Thank you very much.
Dear participants, I'm delighted to welcome you all to this very important meeting on neonatal screening with a focus on familial hypercholesterolemia pediatric screening. Why is neonatal screening so important? Not only it contributes to early diagnosis of certain conditions, which allows the treatment to begin right away, but it also enables families to better plan their child's care and treatment and make informed decisions about future pregnancies. In many cases, such early interventions prevent severe disabilities from developing further and can save lives. Since the neonatal screening became a common practice in Europe 50 years ago, more than 6,000 babies each year benefit from this life-changing intervention, which significantly contributes to improved life with a screenable condition, and that's a reason to celebrate. While data clearly demonstrate the achieved success in the area of neonatal screening, we must continue promoting this practice. We must grasp opportunities offered by increased awareness of the importance of screening and by new genetic technologies which help to identify and treat children with life-threatening conditions. Although such technologies are becoming widely available in our healthcare systems, there is still plenty of work to be done to ensure that every baby benefits from it. We are here today to share our experience and, in doing so, to make sure that these opportunities are open to all children, regardless of their country of origin or societal or economic background. As such, I'm delighted to have experts from 7 member states here today, who will share their expertise and offer encouragement for further efforts in increasing both the number of newborns who undertake the screening, as well as the number of conditions included in neonatal screening programs. Neonatal screening is especially important in the case of rare diseases, which are conditions affecting a small number of people compared to the general population, while often having insignificant impact on patients' lives. The European Union's added value in this field is well known, from the European reference networks to the EU research funding programs. Positive strides have been taken on health-related matters. Extrapolating best practice from member states has also played a crucial role, and it is undoubtedly clear that this extrapolation has improved the lives of rare disease patients. As a former member of the Portuguese government in the capacity of Secretary of State for Health, I'm proud of Portugal's achievement with 25 diseases included in neonatal screening, and I clearly believe that this is an example, a good example to be followed by the rest of the European countries, in line with the need to harmonize European health policies and avoid inequalities between European citizens. This is also the reason why we recognize the very positive work on neonatal screening programs developed in Slovenia, currently presiding the Council of the EU, and we applaud its ambition to lead the European Union towards increasing the uptake of neonatal screening and to enhance its harmonization across the EU. We place great value in the input from other societies, actively advocating for the need to increase neonatal screening. I have the opportunity to speak to you on this occasion, thanks to an excellent collaboration between IPOPI, a primary immunodeficiencies patient organization, and the International Society for Neonatal Screening, who tirelessly strives to enhance the quality of neonatal screening. As most of you know, the established multi-stakeholder Screen for Rare initiative aims at exchanging knowledge and best practices on neonatal screening for rare diseases, to ensure that all babies born in the EU can have equal access to screening, which can be a life-saving tool. One of the current actions under the Screen for Rare initiative is establishing an European reference network expert platform for newborn screening, which aligns with the objectives of this event. We also appreciate the contribution of other patients' organizations, such as EURORDIS. Together, these groups and individuals are seeking support from experts and policymakers to take forward key work streams leading to even greater success in the coming years, and to help ensure that all children of the EU have equitable access to these important and often life-saving services. We owe to future generations this support, and I'm looking forward to today's interactions prompted by all participants. Good work.
Support, it really is appreciated. And indeed, a big thank you to all of the organizations that we've heard of there, who are really working very hard to develop and support good quality and appropriate screening within the EU. We're going to have a short comfort break now, but when we return, we're going to hear from the panelists, and we're going to hear them talk about how they can develop and progress some of the things that have already been talked about. So now is the time to go and have a cup of coffee, relax, but come back ready for this important session in 15 minutes at 10:55. I look forward to seeing you then. Thank you.
Welcome back, everyone. It's a pleasure to welcome our distinguished speakers to this panel discussion, which will focus on how we can improve coordination and uptake of newborn screening across the EU. I think we've heard this morning about, on one hand, the variations that still exist across the member states when it comes to newborn screening programs, but also about many ideas on how we can move forward and ultimately improve and ensure equitable access to newborn screening for all babies born in the EU. I think importantly, we've also heard very strong supportive words from both the Minister of Health of Slovenia, Dr. Koelker, but also from Dr. Manuel Pizarro from the European Parliament, and I think this is very encouraging. I will now pass the end to my co-moderator today, Dr. Peter Cheillan from ISNS, and Peter will welcome, I think, 3 additional panelists who will join us for this discussion.
Yeah, thank you so much, Johan. And yes, we do have 3 panelists that we haven't heard this morning. Hopefully we're able to have just a very short introduction. I would like to start with Mrs. Konečná. She's a European Parliament member from the Czech Republic. And Ms. Konečná, if you would be able very shortly to answer this question, how did you get involved with newborn screening and how did you arrive here today in this panel?
So I'm as one of the member of the mission of the interest groups. That means that I hope that I could speak. So from my colleagues who are in this interest groups, maybe it's very important for you that the mission of this interest group is to advocate for newborn screening. That means that you have a big support in the European Parliament. In EU cooperation of newborn screening for rare diseases is still an underdeveloped area, and we must work on it. Normally, as you know, what means interest group, because this is something, but it's not so known inside outside the EU or a European Parliament. The task of each interest group is to bring together like-minded MEPs, and we usually, for example, submit the joint amendments with my colleagues, or we organize various seminars, or we submit common proposal for pilot project of the Commission. Also, we are drafting common written or oral question of the Commission. However, I have to admit that the functioning of this group highly depends on the mutual personal contact between MEPs. Yeah, it's true, which is currently in this time highly problematic. But we hope that everything going back, and most of the activities of these groups, not only our groups, but these groups have rather stagnated over the last year. But nevertheless, as the pandemic situation improves, their activities can be expected to resume. Yeah, that means that what I can promise you that we going back to Brussels and Strasbourg. I hope that from November everything will be stabilized, and we start work, and we start doing some things what we need to do, because yes, the truth was that the last 1.5 years was a difficult communication, and we, as in another topics, yes, you're doing only what you needed.
Yeah, thank you. Well, certainly you have done already a lot for the Screen for Rare initiative, and we're very thankful for that, and thank you for that kind introduction. We're moving over to Mirjam van den Burg, who is a Dutch colleague of mine. And I do think I can say, Mirjam, that, that you're relatively new in the field of neonatal screening. So my question to you, apart from giving a very short introduction of yourself, is how did you end up in neonatal screening in this field? You're very important for one of the work streams on case definitions. And how do you like the field? So
No.
very short answer to very short question.
Yes, okay. Thank you, Peter. Now, my name is Mirjam van den Burg. I'm an immunologist working in the Leiden University Medical Center. I have done a lot of research on severe combined immunodeficiency, and I did a lot on the diagnostic work. So I enter really the field in newborn screening as from the diagnostic and the research point of view. And the question, how I perceive the field, I think it's very fascinating. And it was already the last years when I led the implementation pilot study in the Netherlands. It was really fascinating how the two worlds of diagnostics and screening came together. And I think that's fascinating for both fields. And I think there's also a lot to gain to further improve the newborn screening. So from the screening point of view, but also, let's say, we as immunologists and more research-oriented people, I think it's really important to join forces, especially also in the context of the ERN, to bring the field forward.
Good. Well, thank you very much for that. And thank you already for all the effort you've put into the field. And let's see where this discussion of today is going to bring us. And meanwhile, our esteemed colleague from the Netherlands, Eugenie Dekkers, has managed to find her camera. Eugenie, you missed the introduction. No, I think you heard the introduction. So just a few lines on who you are, what your function is, and then your short answer on a short question would be, how does Europe affect the Netherlands, the Dutch neonatal screening program, and how do you expect it to affect in the future?
Yes, thank you, Peter. I am Eugenie Dekkers. I'm the program manager of the newborn screening program in the Netherlands at the RIVM Center for Population Screening. And we are running quite a broad MBS program of 25 conditions in it, mostly metabolic diseases, but also sickle cell, thalassemia, SCID, endocrine diseases. And now we are working on starting a program for spinal muscular atrophy, and we try to start that in 2022. And we're also looking into using NGS techniques in our MBS program. So I think we are in a condition of huge challenges and many innovations in our MBS programs. I think that is the main perspective why it is so important to have this international cooperation with each other and to have this European perspective for all of us included, and to see what our colleagues and our experts in other countries are doing, are learning, and that we can learn from each other, and even making our programs stronger and better and making it a real MBS system, because I think that is what is needed, and that is why it's so important also about this European meeting. So thank you very much for this.
Thank you very much for those encouraging words. And before Eugenie, and then before I give the floor to Johan, this is really for our audience. I heard that meanwhile we may have had 130 registrants, which is really quite so we're quite happy with that. If you have a question to the audience, to the panel, to one of our panelists, please type in the question into the chat box, and we'll try to answer those questions in our last part of this meeting, where James Bonham is moderating a session with the audience. So Johan, back to you.
Thank you very much, Peter. So we'll kickstart this panel discussion with one question. I think it was clear from all the presentations. We talked about some of the differences in terms of newborn screening programs around the member state, but also some of the solutions. But a couple of speakers also touched upon the fact that we are really awaiting almost a revolution of the newborn screening field with genomics potentially changing how newborn screening may be carried out in the future. So a first very general question would be, is this a special momentum? You know, are we at an important turning point in the newborn screening journey? And would that be an additional reason for the EU not only to take a role to try to help with better coordination, but also to take a role for making sure we are prepared as a European Union for the future. And I'd like to turn this question to the whole panel. So feel free to raise your hand if you want to start. And if not, I think maybe I will ask a couple of people myself. Anyone would like to volunteer for this first question?
Maybe me, because yes, it's true that it's about the EU and maybe a little bit European Parliament, and I want to be open. Yeah, you know me, and I not like it. It is political answers. That means that I will probably disappointed you a little here, but the European Parliament cannot do much more on this area than is has already done, because we are now basically moving on the right edge of the possible. The problem is primarily EU law, and neither we nor the Commission can order member states to provide these screenings. We can send them more and market funds just for this, but the member states themselves would have to do this and send more money into the EU budget. And we can, of course, put together a proposal with the Commission, which would state in a non-binding manner that such screenings should look like, etc. But that is all. And we cannot even harmonize the design of these screenings. Yes, it's really impossible. And the Council can, for example, update its recommendation on rare diseases from 2009. In terms of implementation, member states will face the lack of funding. National healthcare systems are completely depleted after the pandemic, and budgets are tight. And according to proclamations, the fight against cancer is a higher priority now. Yeah, it's not from my side, but it's reality where we are. And the budgets are tight, and according to proclamation, the fight against cancer is really something what it's the top. Yeah, I understand you and your position, and really please believe me that it's not from my side a good decision, because I think I understand why cancer is so important, but in the other side, I know how many other diseases we have it in a EU, and all these diseases, nothing is preferable or not. Yeah, we need to help anybody, but the truth is that if you see on the funds, if you see on the money, on political statements from, for example, Madame von der Leyen and all these people, you can see that it will be very difficult work. But in the other side, from my side, I promise you that we're doing anything what it's possible. Yeah? But I don't want to give you some best answer and say, okay, everything will be next year the best, because we have a big issue there. One is a primary law, and the position from member states, and the second needs to be more in a council of EU, not in a European Parliament, because I think that from European Parliament you have a support, and we support you. But now the concrete steps need to come from member states and from Commission, and especially from their budget.
Well, thank you very much, Mr. Nechna. And I think absolutely agree. I think navigating the policy priorities at EU level will be very important. And I think that's exactly why the MEP interest group on newborn screening will be important, because it does provide a platform where we can bring together all European stakeholders and try to move forward. Now, of course, today is a testimony of a member state prioritizing the topic, which we are highly appreciative about. Perhaps I'd like to pass on the hand on the same question to either Professor Bonham or maybe Professor Scarpa, if they have additional observation with regard to this momentum and why we think the EU should get involved, and also how should the EU get involved.
Yeah, I can start. I think your question, Johan, was particularly does the genomics revolution bring something different? And I think the answer is that it does. And that's why it's important that we organize ourselves and ensure that we don't take missteps, ensure that we take advantage without going down a wrong route. And it's different because, of course, it's slightly further away from the patient. So when we begin with a clinical presentation, we have, if you like, a clinical prior before we do any laboratory investigations. Screening doesn't do that. It starts with an asymptomatic child. But of course, there are biochemical disturbances which are nearer the phenotype of the patient. And even with that, sometimes it can be a little confusing in the way that Stefan was talking about earlier with isovaleric acidemia as an example, where the biochemical finding doesn't necessarily equate to real disease. And as we step even further away into the world of genomics, then of course that can bring new challenges and new uncertainties. And so I think we've got to be very careful of that. And of course that sits alongside huge commercial interest, because of course the means of detection that genomics offers is also accompanied by a means of treatment that genomics offers. And these are very expensive treatments. And what that means is profound commercial interest. And of course, provided that commercial interest is handled in the right way, it can bring great benefits for our societies. But if it's handled in the wrong way, it can be not just an economic burden, but also sometimes a burden of uncertainty for the families that have been touched by this. So I think it really is absolutely crucial that we act, and not just act as individual nations, but act corporately together as a European community, and to develop clear guidelines, to have a clear and unbiased place where we can discuss and take advantage of the good things that genomics has to offer, but perhaps express some degree of caution when that may be going in the wrong direction. So there's never been a more important time to work together because of genomics, to exploit the benefits, but to avoid the pitfalls.
Thanks so much, Jim. And I see we have a couple of people who've raised their hands. I'll go not in order of preference at all, but in order of the pictures on my screen. So starting with Maurizio Scarpa, please.
Thank you very much. Yeah, congratulations also for how the meeting is conducted. And it was very clear, very precise, and very important messages have been delivered. Regarding the question you had, Johan, regarding the gold momentum, we are indeed in a gold momentum because we are here today with all these stakeholders and so many MEPs, and the moment of collaboration and to create really a unified effort on this important health action. We are in a gold moment, but I think that we need to be very careful because, I mean, as Mrs. Connection was saying, probably we are not ready now to have a European newborn screening program. We need still to work. And this meeting today is stating that we have the basis, that we have the platform to do. We need to be very careful in which kind of technology we want to use. We need to also be very careful in how many diseases we want to use according to the therapy availability. So there are quite a lot of issues that we have indeed still to discuss. And we have the time now to prepare this discussion in order that also the European Commission and the European Union is ready for that. So I think that we should not cut angles, but we should actually now from today, having formed this task force, start a discussion, which is a continuous discussion involving all the stakeholders and having the patients with us in order to prioritize, to identify first the needs that are still open, to prioritize actions and to create really a very reasonable way to go. Because it is true that there are countries which are really example and piloting the newborn screening, like Italy, for example. There are others that are willing to do, but probably do not have the tool yet. And we have the ERNs. As I said, the ERNs are really a sort of collaborative network that can really be used also to cover and to speed moments. Especially now that we are going in the second 5-year program, we can really ask to the ERNs together with the member states and the patient organization to identify a program inside each ERN in order that each ERN has a specific task for newborn screening, because it is not only biochemical, it is a lot of genetics. And all the rare diseases are taken care by the ERN, so to design a program that will expand for the next 5 years in a very coordinated way. And this is a message that I will bring to the ERN coordinators group, because we have one group which is working very intensively all together in order that this action is forwarded and it is actually expanded together with the marvelous platform we have constructing today with societies, the ISNS, with EURORDIS, with the ERNs, with the state, with the members of the parliament, with the expert that can help in designing the way.
Thank you, Maurizio. I absolutely agree with you on the role of ERNs, and I think we'll have the opportunity, hopefully, to discuss more specifically some of their actions. Yann Le Cam had raised his hand as well. So Yann, please, the floor is yours.
Thank you, Johan. To follow up, in fact, on what Maurizio was saying also, and on your question, the momentum is clearly in the screening technology with the genomic revolution, as Professor Bonham elegantly explained. Also, the fact there is new treatment technology coming in, and often with potentially a curative effect, and where the optimal outcome of the treatment is when it is associated with a newborn screening, because it's before the appearance of the first symptoms. So that's a game changer, and that's a new conversation around newborn screening. Also, the growing differences, which we heard very well this morning across EU, but also more broadly across Europe, which from a society standpoint, from patient family standpoint, is just not understandable. Hearing that we still have an ongoing process of pilots for cystic fibrosis in Sweden, when cystic fibrosis is being tested, screened in other countries already since 30 years in pilots at that time, it's just difficult to understand. Now, there is other elements of momentum. The European reference networks are changing the game, because we have network of experts to discuss the good clinical practice and the benefits and risk of newborn screening. So we have a pooling of expertise. But there is also a new important element, the new European HTA legislation. And we have not mentioned that until now. In the scope of the collaboration on HTA at European level, all the technologies linked to newborn screening is completely eligible. So instead of having conversation in our respective national HTA agencies, 60 across Europe, we will have it in the future within this European collaborative framework. And that's a major difference. I'd like to insist on that, because it means that it provides us the framework to discuss the level of evidence which is needed to inform the decision at national level, which gives us the opportunity to coordinate the efforts of the pilots, rather than repeating the pilots as we're doing from one member state to another over a period of 10 to 20 years. I'm pretty sure that there is a better way to use our time, our money, and our capacities of human resource capacities into the health systems. And the reason to collaborate at European level is obviously the standards. So here we're talking about harmonization, but it's very much bottom up. It's from the professionals who elaborate these standards, either from the societies on newborn screening or from the ERMs, and also to exchange or practice around the process. Each of you insisted about the importance of the process, the organizational aspects, and we know how much important they are. And here there is a lot of peer-to-peer learning across member states, and that really technical level and bottom up. But the biobanks are very important, and this is the critical mass of Europe. It's an opportunity we shouldn't miss. And here, in these two areas, maybe there is a role for GRC to play. GRC is responsible for quality and quality assessment and helping member states with that. So it's not a top-down approach. It's usually very much a bottom-up approach, as we have seen in cancer, for instance, for screening of breast cancer, just to take one example, or early diagnostic of breast cancer, I should say. Having a platform or a steering committee of experts with stakeholders involved. By stakeholders, I mean ERNs, patient representatives, maybe other we have to see, is absolutely essential to maintain the momentum of today from this workshop. And I really praise the Slovenian presidency for this initiative. And to conclude, from the top-down approach, what the European Commission can do by including newborn screening within their work program of EU for Health is to support that steering committee, is to support this exchange of best practice across member states. And here the SGPP can play an essential role, starting from few member states which are ready to collaborate more together before scaling up across Europe. Also, they can fund research activities or activities between professionals on the methodological aspect and the funding of the evidence on the pilots. So funding the pilot to generate the level of evidence to inform decision-making across Europe. That's cost-effective at the European level. And last, the non-binding legislation that was mentioned by your Slovenian colleague today, non-binding or Czech Republic, is that non-binding legislation is useful. So EU can also develop a non-binding legislation down the road to make recommendations in order to really encourage it to be more thorough across. Thank you.
Thank you very much, Yann, for all these additional very good points. I think Eugenie as well has raised her hand, so I'll pass on the floor to you.
Yes, thank you. I also wanted to give one more reflection on this momentum that we are seeing, because also with us in the Netherlands, we see this momentum for newborn screening at a European perspective. We started a vision project for our MBS program with our Ministry of Health to look into the future of newborn screening for 10 to 15 years further. Because we see all these developments with new techniques, NGS, new innovations being possible for our MBS programs. So this is what we start to look into creating a more strong and viable MBS program in the Netherlands. And our Ministry of Health also asked us to look into European experiences. So experiences, developments, models in other European countries who also have these MBS programs, to see what we can learn from this and to have this also available for this vision project into a more viable MBS program in the Netherlands. Thank you.
Thank you very much. And I think, I mean, obviously a great discussion ongoing. Maybe to come back, we've mentioned, and Maurizio and Yann as well have touched upon the role of the ERNs. Now, we know that the ERNs recently launched an expert newborn screening platform with several ERNs really fully engaging in the initiative. Perhaps I'd like to ask Jim to provide just a quick overview of the different work streams that have been agreed, and then maybe Peter can follow with some questions on some of these topics with some of our speakers who are very much involved, before we perhaps come back to more policy-oriented discussion. Hopefully we have time.
Yes, thanks, Johan. We've distilled this down to three, just to get things beginning, three important and key work streams that have come out of that work with the European reference networks, and we hope to develop within Screen for Rare and indeed on a wider stage as well. And those three are building upon the work that Gerard Löber and Peter Cheillan have already done at looking for practice of newborn screening, not just the number of conditions, but also how the program is run and organized across Europe, and see whether we can develop that and learn from one another. And this is part of that process. it's really learning from good practice. So for instance, just as an example, we heard this morning from Giancarlo Le Marca about the importance of second-tier testing to improve the positive predictive value and avoid false positives in the Italian newborn screening program. And that's something which should become standard across most of Europe. And we need a strategy to work out what that would mean for our programs and to develop that to include not just the number of conditions screened, but also the quality of that screening. So that would be a piece of ongoing work. How can we learn from one another? How can we improve governance? How should we be monitoring our programs? The second is key, and that's being led and coordinated by Miriam, but clearly with input from others. And that is, how do we define the conditions that we identify? It's seemingly obvious, but as Stefan dramatically highlighted this morning, the term isovaleric acidemia means different things depending upon the type of condition that's identified. And just how do we define the conditions that we identify at screening leading to treatment? It's seemingly obvious, but we don't necessarily have agreement. We certainly don't have agreement across the world, and we don't even have agreement across Europe. And that's pivotal to think of how we then go on to develop screening and treatment for those conditions. And then the last is the important emphasis upon outcomes. It's remarkable that we've been doing screening for 50 years, and we're only now beginning to look in a systematic way at the impact that that's having in the lives of children who've been touched by that. So that's got to be a key part of our work, because it's when we can demonstrate that impact that we kindle the interest of our health policymakers. And so that work, which again, Stefan mentioned this morning in Germany, but it's not just going on in Germany, it's going on in other countries across Europe as well. In the UK, we're having a renewed emphasis upon the importance of outcomes. And so we want to work with that. So it'll be those three areas: identifying good practice, being clear about what we mean about the conditions that we identify, and then looking at long-term follow-up for some of these cases so that we can demonstrate the impact and benefits, and also learn how we might improve newborn screening programs.
Thank you very much, Peter. Perhaps I should hand back to you for some follow-up questions on these matters.
Yes, Johan. Well, first of all, there is room for the panelists to comment on these work streams. I see hands from Viktor, surely, and from Mauricio. So we'll start with Viktor. Thank you, Viktor, and then Mauricio.
Thank you, Peter. I have still one comment on the on the use of genetic technologies, which we all here in this panel discussion are convinced about the importance of newborn screening program. But about 5 to 10 years ago, there was a campaign throughout Europe where part of population actually questioned the possibility of using dry blood spots for any genetic testing and for misuse of the data. So I'm just making a note that if we are talking about the stakeholders, we should probably involve a larger population, not only those who are involved in screening and patient organizations who benefit from screening, but we should also listen to the other part of the population, as we do see it now, for example, in COVID vaccination. The second point I wanted to comment was that of Jim Bonham. I'm just wondering whether we can define cases without knowing the outcome and the clinical benefit we are doing. So I'm just asking whether this is not actually intertwined. By having the data from long-term outcome, we can retrospectively define what is the case. Thank you.
Yeah, well, absolutely agreed, Viktor. And while designing these work streams, we on many occasions came to the conclusions that even the work streams are intertwined. And there's data from one work stream that is necessary for the others. So quite agreed on that. Also, you mentioned genetics, and I see in the chat box that we receive a number of questions now on genetics and newborn screening, genetics in particular, and it seems to me that especially is a subject that you want to address on a European level, as you yourself mentioned in your presentation that you're now trying to change the law to make it possible for genetic screening to be introduced. There's also regulations in France. David could maybe allude to that. I think you need to ask specific consent for genetic screening, don't you, David? Wasn't it the case with cystic fibrosis screening? This is a question to David Cheillan. Your mic is off now, David. David, your mic is off.
Sorry. Thank you, Peter. Yes, but the discussion in France about genetic screening for cystic fibrosis is quite different, because it was in the beginning of year 2000, and the place of genomic was quite different. And when we start, the discussion was we have a first year test with a biochemical test, and after that we plan to add the genetic part. So I think that actually the question is very, very different, and the acceptation, the acceptable of the genetic screening in the general population should be really different. And with the time, we have a number of parents refusing newborn screening, increasing in France. In the beginning, it was just maybe 10, 20 per year in France. And actually, it's maybe several hundred, in part, I think, due to the genetic screening. So if in the future you had a global genetic screening as a first year, I think that a part of the population should refuse newborn screening for each disorder. So it should be a problem for the future.
Yeah. Okay. Well, believe that I'm pretty sure that we will not finish a discussion on genetics and newborn screening in this panel. But I do think that there's so much room needed for this discussion that maybe at some other point we need to organize a special event on this. But and I also think that this is a message to Katarina, that there's so many questions on a national level already, and so many diversity given all the subjects of neonatal screening, but especially in this emerging field of NGS, that there's grassroots initiatives as we're looking at one today, but some guidance from Europe is so much needed. So any help you and your colleagues can give us in that respect is much welcomed. Now, maybe one short comment from you, Katarina, and then I go on with Miriam, and then Jan, and then Mauricio.
Only short comments. Yes, as I said in the beginning, I hope that we start new work in our interest groups, that I will contact the colleagues, Mr. Pizarro, and I think that if you will have this input, please give us, and we will contact you and discuss with you what will be the best here, because we have some possibilities what we can do. Something is better, something is not so, but we can give you some options, and I think that we will discussing this in the end of this year or in the beginning of next year. Yeah, but I hope that in the end of this year will be the time to discuss what our interest group preparing for next year, and this topic could be one of the main issue from our side. It means that I promise you that we did it. We do it.
Oh, please make a note already, and we'll come back to you. Thanks for that, Katerina. And now Maurizio, Jan, Miriam, and then Giancarlo. And then maybe just a short break to see where we are and how we proceed. Maurizio.
Thank you very much. The discussion is very interesting. On the clinical side, as a metabolic physician, I would like to stress the importance of to consider newborn screening as a system, and not to concentrate only on the technology. The newborn screening is involving also a lot of other disciplines like nurses, like obstetricians, gynecologists, and psychologists in order to assist the family. This is something that is becoming more and more urgent because there is quite a lot of awareness. There is a lot of expectation in the general population from newborn screening. But we need to consider the newborn screening inside a major action which is surrounding the birth. At the moment, I have to say there is still quite a lot of lack in awareness on disciplines like gynecology, nurses, and psychologists. And what we are trying to do inside the ERN is indeed to involve these people in order to create a course and to discuss newborn screening directly in the pregnancy. Before the birth, which is the moment in which usually the discussion of newborn screening is done in most countries, and especially to follow up the families, not only when they have a sure diagnosis, but also when they have a suspect, because unfortunately the newborn screening still has a small percentage of recall, which is creating a real drama in the family. And this is something we need really to take care together with the expansion of genetics and other technology.
Okay, thank you for that comment, Maurizio. And then Miriam.
Thank you, Peter. I would like to continue with the vision Jim Bonham made about the different work streams, and I really agree that they are really interconnected. And what I would like to add on that, we've been working on the case definitions for severe combined immunodeficiency for SCID, and Rolf Zetterstrom was also involved. And what we did, we sat together with screeners, immunologists, clinical geneticists to talk about the case definitions. And I think the way we did it, so to talk with others, to also did a systematic review from literature, which terms are used, and then finally coming up with case definitions for a disease, not only by the clinician, but also by the screeners. And I think this way of talking together is, I think, very important for the field of newborn screening, because if you have uniform definitions, only then you can make fair comparisons for the strategy, but also for the outcome and the registrations. So I think the ERNs could play really an important role in this, because we did it for SCID, but I think similar approaches can also be valid for the other screening programs. So maybe also Rolf can comment on that, because you are more from the screening side. Maybe you can reflect on that, Rolf?
Hello, no, I really agree. And I think this is really a challenge that we have to talk about. And I mean, Jim said something about trust in the families that we work for, and Maurizio also mentioned that it is really important what we do. And I think that you can see different views, even from professionals, if they have been doing and working with screening for a long time, or if they haven't. Because I think they regard a false positive a little bit differently. And this is something I have really, really understood while jumping into the field of primary immunodeficiencies, which is not my background. I have a similar background to Maurizio, and as a pediatric metabolic doctor and endocrinologist.
Thank you. Sorry, Rolf, please finish.
No, I think it's
good. Yeah, then well, that certainly was the study of Miriam was a very nice spin-off of a conference we had earlier this year on SCID screening, and it is an example how we can deal with case definitions. We're running out of time, so I would like to have very short comments of Yann, Giancarlo, and Katerina, and then I would like to hand back to Johan for maybe one last question. And then I think it's time to see whether there are questions in the audience that we could relate to the panel and to Jim. Is that okay, Jim? Johan, is that what we're going to do now?
That sounds good.
Okay, so very short answers from Giancarlo and Katerina then.
Okay, thank you very much. I'm really learning a lot of things today, and just a small comment on genomics and the revolution of genomics. Genomics is a quite complicated word, I think, and we have to pay attention, but we are still using molecular biology in newborn screening field. It's not the future, it's the state of the art. We are using molecular biology for cystic fibrosis, for SMA, and also for SCID. Therefore, I believe that the information and the formation of parents is a critical point. And we have to give right information in the prenatal period to families and involve them. We are discussing about a multidisciplinary program or system, and that's the meaning. We are all together, families, professionals, and we are using molecular biology as confirmatory testing. Confirmatory testing is a part of newborn screening program, and that's a fact. It's not the future. It's the state of the art.
Thank you, Giancarlo. Katerina.
Thanks. Only shortly. But just so it doesn't look like anything's happening in a European Parliament, I think that we so need to say that the topic of rare diseases, the research and development of orphans and screening is slowly, but being promoted in all legislative documents that we are discussing today as a part of so-called Health Union package, especially after the pandemic. There is a great will to adopt a new legislation in this area. If you look at the latest voting on a new EMA or ECDC mandate, or the compromise on the INI report on the pharmaceutical strategy for Europe, you will see that the topic the topic of rare diseases is significantly present in them. That means that yes, it's a win, but we want more. Everybody understands, but it's not so that the rare diseases is somewhere. I think that we with the EURORDIS are doing a great job, and we will continue with it.
Well, thank you. That's very encouraging, Katerina. Yann.
Thank you. First, our discussion shows that we absolutely need this expert forum or steering committee with member states, experts or stakeholders. So it would be fantastic if the Slovenian presidency was elevating that to the EBSCO meeting in December, if you think that's what fit for purpose for member states. My second comment is on the point on how do we define conditions. I'd like us to be very careful not to be systematic in the equation, newborn screening, expensive treatment. No, definitely no, because first there is treatments which sometimes are not expensive. May I take familial Mediterranean fever, for instance, where we still don't have newborn screening. It's very cheap and it can really improve the life. So what we're saying is that we need to look at health outcome and social outcomes, and that in fact, if we were looking at these diseases where health outcomes, social outcomes can be improved thanks to newborn screening, we will then not have that equation with the expensive treatment. And my last short comment is to say that I fully support the comments of Professor Bonham and Mr. Kožich about the trust, and it's a treasure to protect. We need to be very careful in the design on how we scale up newborn screening so that the population maintain that trust even when moving toward more genetic screening. But also I would like to mention, in reference to the colleague from France, that I don't see a problem of having family refusing to do newborn screening with genomic technologies. And maybe that's also something we need to think of, that maybe we need that kind of freedom, that people have the right to choose to be vaccinated or not vaccinated, have the right to choose to have newborn screening for their kid or not, that this is private choices, exactly like we accept that there is no blood transfusion for some families for religious reasons. We may not like it, but still, we're a society where everyone can have his own convictions, and I'd rather go in that direction than imposing things on the population, which will slow down the overall process. Thank you.
Yeah, thank you for that comment, Jan. And now back to you, Johan.
Thank you. I'll be very brief, Peter. I think we've had an excellent discussion. I think it shows we could have gone probably for another few hours because there are so many aspects that are so important. I think if I would summarize some of the discussion, we've heard a lot about the clinical and scientific and research role that the European Reference Network can play. And I think that is definitely one of the pathways in which the EU can help. And then the other pathway is obviously the policy related pathway, which is very important. And I fully agree with what Yann has said about the importance of having a standing committee. I think that has come through a lot in the presentations already and makes sense in light of the discussion that we've just had. I would say my final observation, and maybe if there's a rapid comment, that'd be great. But obviously today, I think for me is an event that should be seen as a stepping stone for more at EU level, more action at EU level. We have, I think, two people with us on this chat, and maybe Ms. Konečná has no left, but from the Czech Republic and France, which obviously are two member states who will be part of the next presidency trio. And I think it would be great to continue what Slovenia has started with this event and their support when it comes to the future presidency trio. And that would be my closing comment. And perhaps if David Cheillan from France has an observation on that to close up before we pass on to Jim.
Thank you for that. There is a huge work for the future. So if we could continue something, it will be with a good pleasure with everybody, of course. Thank you so much.
Excellent. So Jim, I realize we don't have so much time, but we have a few questions from the audience, I believe.
Yes, let's begin to move into that now, Johan. Thank you for everyone that's contributed to that. We could have talked all day, but we want to make a bit of time now to hear from the audience, those who are registered as attendees and who can put questions in the chat. And I wonder, Johan, what do you think? Where should we start with that? Are there some questions in the chat?
Yes. Yeah, I think we could start with one from Virginie Bros-Facer, if I'm pronouncing that correctly. And she says, the UK is already embracing the genomic revolution, and Genomics England has started a public dialogue on the UK about the use of whole genome sequencing in clinical diagnosis through the NHS and in the future for NBS, so for newborn screening. And then it's her plea that the EU should take some lessons from such an initiative. That kind of rings a bell with what Eugenie Dekkers just mentioned, that in the Netherlands there is this vision on the next 10 to 15 years on newborn screening. So how, I guess the question to you, Jim, and panelists is, how are we going to collect all that knowledge that is already there and not available for the European community as a whole, and we as professionals as a whole? Jim?
Yeah, I mean, I think I would say, please don't take lessons in the EU from the UK. They're not always good lessons. That's probably the first thing to say. But on a more serious note, I think we do have to learn from one another, even the UK. And we've got to collect that information and store it. And that's part of the work of Screen for Rare and the Health Technology Platform, to be a trusted repository for information. Coming specifically to that work of Genomics England, I think it would be wrong to say that the UK had embraced genomic testing as a way forward for newborn screening. It's certainly keen that Genomics England is quite keen to explore that. And they did do an extremely useful public dialogue, and that's available on YouTube. It lasts 1.5 hours. If you haven't listened to it, then please do. And what the public in the UK at least felt was that they were interested and optimistic about embracing genomic technologies. But if they did, they recognized that this could be a real shock for parents, and parents would need to be very carefully supported and prepared to engage in that form of testing. And we went on to use the same team, actually, interestingly, to explore the use of next generation sequencing in cystic fibrosis, which was much more defined, just to go from the IRT then onto DNA, but not the limited panel of mutations, using the full power of next generation sequencing before we came back to IRT. And that was really interesting, because what that same public group that had offered input into the consultation organized by Genomics England, what that group said, of the public said, they started off thinking, well, this is great. And then as the series progressed, we did this iteratively with experts with the same public group. They moved from a position of unbridled optimism to much more caution. In fact, they finished with prizing certainty over sensitivity in screening. And these were not, as I say, these were just members of the public. And that taught us a lot, because what the question we were asking them is not whether we should do it, but how should this be used? Should it be used only to identify certain cases, or perhaps used a little bit more comprehensively if there was any form of risk? And progressively, the public moved away from any level of uncertainty to only uncertainty for clearly treatable conditions. And I think that was really important for us. And I suspect as we move on in the genomics revolution, what we've got to be really careful about is that when we're talking about newborn screening, we're talking about community-based activity in which we're reaching out to families with well children. Yes. And the crucial thing is to protect those families. If we can then go on to identify children with disease, then of course we must, but we must not lose this huge confidence and trust that the public have placed in us to protect the families with well children. That's got to be our first responsibility. Do no harm. If we can do good as well, then that's great.
Jim,
thank you, Jim.
Johan, if I'm just, if you allow me just one more minute or maybe two to make a little bridge, Jim, we've in the discussion, we have now discussed newborn screening and neonatal screening on so many levels, on the level of how to engage with the public, how to build trust in neonatal screening programs, genetic screening, biochemical screening, etc., etc. And we all try to move that into a more European realm and area, so to speak. And you, for one, have said that we actually need a standing expert committee for newborn screening in Europe. And it's been alluded to in several presentations. Could you just give us an idea of how you think that should work? And then maybe some of the panelists could comment on that as well. Let's take 2 or 3 minutes to do that.
Yes, I'm going to hand that over to the panelists. I think that we need an expert committee that really doesn't just talk to ourselves. I'm very conscious that on this group, we've got a lot of people with an interest in newborn screening and a lot of support organizations with an interest in newborn screening. We've got some politicians, we've got relatively few members of the public, and I suspect no health policy decision makers. And so we can talk to ourselves endlessly about what we think are good ideas and the way that we should progress newborn screening. But unless the health policymakers in our European countries are asking the questions and listening to the answers, we will simply be talking to ourselves. So I think the first thing is to have an expert group, but it's an expert group that should be built around and formed around the needs of health policymakers. But I'll pass over to the panelists to what kind of group that would be.
Yes, so I think that there's then three important questions. Where should that expert committee be housed? As a separate organization or next to another European organization, and who should be in it? I think for the next few minutes, we can discuss that and maybe not more. So who can I give the floor? Maurizio, you have a strong opinion on this.
Yes, thank you very much. I think that it is, as I said before, it's very important that we have this newborn screening expert group, because a lot of activities, a lot of awareness has been raised in the past 3-4 years. As we said, there is a lot of technology, there is a lot of other important issues that need to be addressed as a circle and as a system. Again, I think that the ERN can be the right side to do this, because we have all the disciplines that are indeed necessary. We have also contact with patient organization, EURORDIS first, and all other organization, IPOPI and other big ones. And we have also the support of the European Commission. Furthermore, we have also a vision because the ERN is a program, is not a project, so we have long-term actions, and we can apply, also to competitive programs for artificial intelligence, as we did just in September, 5 years all together for an important action. Mm-hmm. So I think that this could be really the right way to go, and we are very keen in helping and facilitating this, because it's really an important issue.
Maybe Katerina, could you, in your wildest dreams, or maybe not so wildest dreams, think of a possibility that we were able to realize such a standing committee?
So it's a difficult question, yeah, because yes, in my dreams could be, and in my dreams is many things how I can help this topic and the people with rare diseases, because this is, I hope, something when I could be useful. But yes, we could try. But in another side, I don't want to give you only my dreams. Yeah, that means that, as I said before, it's step by step. You need to change. Now is the time to change many things, because many people in the European Parliament interest about the health issue topics. That is something what's we haven't from the beginning, yeah, because last mandate, for example, interest about this topic only 7 people maybe from whole parliament. Now it's situation another. But the truth is that it's not will be easy, and it's not will be next month. But yes, we could cooperate on it, and I help you as is possible.
Well, that's great to hear. And I learned from Maurizio's presentation that it took about 10 years before legislation to realize the ERNs got from the first grassroots initiatives to legislation. So we may lend ourselves some time. Back to Johan.
Thank you, Peter. And I'm not sure whether I should go back to Jim, because I know we are running a little bit over time and reaching, I think.
Yeah, maybe we should work to a closing. Could also be appropriate. I think we have 5 minutes left, have we?
I mean, Jim, maybe just to say on the basis of the other question, there's certainly support for this expert group on newborn screening. I think that has come through a lot of the question and a suggestion to update the Council recommendation for rare disease and include that. There was also a couple of questions about impact of family, but I think from the genetic screening, I think you covered that already, partly at least, in your previous response. And then probably another one was the importance of awareness and how we can raise awareness together, because we are all stakeholders from different sides of the topic of newborn screening, but all really wanting to push the topic forward, and that might, that creates an opportunity to do things together. I mean, certainly part of my answer would be to look at the International Neonatal Screening Day, which has been held for the first time on the 28th of June of this year, and obviously will be held again in the years to come, and that might create a momentum in our calendar for 2022. But I think, Jim, maybe it would be time to go back to you with some concluding comments to this session. And thank you, of course, to all the panelists and to Peter, my co-moderator.
Thank you, Johan. And yes, I think it is time to begin to draw things together. It's been tremendously interesting this morning, tremendously interesting to see and hear what's happening in our various countries. And of course, these are only a selected few. There's a lot going on in countries that we haven't had the opportunity to hear from this morning. I mean, I think to try and distill this, I think we all see the value of newborn screening. We rejoice in the fact that it broadly has strong community trust. In countries where this is optional, then the uptake rates are extremely high, the coverage is extremely high. And so the first thing we've got to do is to continue to value that and protect it and build confidence and trust. And don't take that for granted. Build confidence and trust with politicians and with the public. I think we are going to see new technologies. And so I think, like it or not, I think we've got to try and take advantage of those. But as I say, like it or not, it's probably down to us, the newborn screening community, to see where those new technologies fit into newborn screening with all the potential benefits, but also some risks attendant upon those. A key way of doing that is to be inclusive. I've seen one or two chats in the comment there about having a widely drawn expert group, including ethicists, including payers, including policymakers, alongside those of us that are advocates for newborn screening. I think we need to provide, if we can, unbiased advice, certainly unbiased from commercial interest, but also to some extent a step back from the urgency which individual patient organizations would perhaps attach to their disorder. That's not to dismiss them. The patient voice is hugely important, but I think we've got to take a slight step back and try and look at newborn screening in the round, because of course, when newborn screening is presented to a family as an option, then it's a series of tests and not just a test for an individual condition. We've got to be careful that we don't talk to ourselves, and that we include particularly, as I say, policymakers. And I think we've got to be careful, and Peter touched upon it, that this is not a sprint, this is a marathon. This is something that we're going to build carefully and methodically year after year after year. And we're doing that at the minute. We've had a series of meetings. We mentioned that meeting, which was the ERNs in September. We've got this meeting today. We've got a meeting in a month's time in Luxembourg, and that's not chance that these things have happened one after another. And then we hope to have another ERN meeting in January. But that's got to be supplemented, this talking's got to be supplemented by documentation. And so Peter and others working with the IJNS, the International Journal of Neonatal Screening, are intending to dedicate a special issue that I long for all of you to contribute to about screening practices in Europe, so that we can get some of the things that we've talked about this morning into peer-reviewed published journals for the long term. This is a marathon and not a sprint. And of course, Johan's already mentioned, please do begin to think now. If you don't think now, it will not happen. Begin to think now upon the events that you're going to be involved with and perhaps help organize for June the 28th, 2022. I think I'm going to finish where we more or less began, that the crucial thing is to get together an expert committee but not just drawn of those of us who are already convinced, but an expert committee that enjoys a degree of recognition by the European Commission, that enjoys political support and is widely drawn. And that's what we'll be turning our attention to again and again over the next 2 or 3 months. And I think that's where where I'll leave it. We've got a lot to celebrate. We've got a lot to do, and we've got to plan and work together and really trust one another. We cannot engender trust from others unless we trust one another. So let's press on together, and thank you hugely to Urh and the Slovenian team who have organized this, to the politicians, Katerina and Manuel, who have been present and offered support and encouragement. And of course to Tadej for hosting this on behalf of Slovenia. So thank you very much. It's been a hugely beneficial morning. Thank you.
Yeah, I would also like to thank everybody for this early great energy with this meeting and for good attendance. And I'm looking very much forward that it will continue like this.